She completed her Bachelor's of Science in Engineering Physics, the mechanical option at Queen's University, and she completed her PhD in biomedical engineering with a specialization in medical imaging here at the University of Calgary. And some of her research interests include medical imaging to assess bone morphology and mechanical regulation in vivo. And some of her previous work was related to understanding the characteristics that underpin osteoporosis. And currently, her focus is shifting toward investigating the impact of chronic childhood diseases on bone growth, fragility, and fracture healing. So thanks for joining us today, and we're excited for your presentation.
Perfect, thank you. And actually, I don't know, is there an ability to turn down the lights just in the immediate front, or is that a hard to do? Just, I realize it's probably going to be hard to see some images. Ah, perfect, okay.
Oh, wait,
yeah, just.
Let's open the blinds.
Oh, sorry. I should have. Oh my God.
Yeah, that'll just turn off that front row.
That work better? Sorry, I don't want to stir the pot.
Put it back on.
Yeah, and then we can do. Yeah.
Is that better? That's gonna. Cool. That works. I don't have too many hard ones. Go back? Yeah. Okay. There you go. All right. Great. Okay. Well, thanks for having me and all that, and thank you very much for accommodating. I think there was some challenges with scheduling and all that, and I know it's always difficult organizing these things. So it's great to finally make it here and talk a bit about my former research. Well, a kind of a continuation, but I've left actually the branding from my postdoctoral fellowship because this work is from that. Although, of course, I am here at the University of Calgary and fully, I guess, patriotic for our institute. But yeah, today I'm going to be talking a bit about fracture healing and investigating quite a complex biological process that has kept me busy. Actually, it's always been in the back burner of my research during my PhD, and then kind of came at the forefront during my postdoc. And incidentally, I just submitted another grant to study it more. So I guess I like suffering a bit, but there are some very interesting mechanisms that are at play. So before jumping in, if this works. There we go. You got a great intro of who I am and where I'm from. So I won't kind of belabor that, but I did want to highlight that during my PhD, much of my research was focused on clinical imaging, particularly looking at an area of interest for me is characterizing really atypical amorphous bone structure and understanding how it came to be that way and how we can better quantify that beyond our standard metrics that are available. As I shifted to my postdoctoral fellowship, I did look to kind of get more expertise in training and advanced computational methods. And a lot of this actually focus more on preclinical imaging, where you can manipulate your subjects a bit more and get a lot more fine detailed information. So here, for instance, looking at detailed changes in bone morphometry with mechanical loading in mouse models, and as well as doing ex vivo samples and imaging bone structure at different scales. And this will bring into play on what I talk about today. So of course, as I mentioned, fracture healing is the focus here, and in particular, I've been looking at distal radius fractures. And a big reason for that is, of course, we can image this much easier than other sites. But here's just an example of a 3D structure that we can get with the scanners that I use. So for those that might not be too familiar with fracture healing, just to give an overview of the processes, which many of you probably have either experienced firsthand or are familiar with it one way or another. When we fracture a bone, of course, it hurts a lot, and it causes an immediate response, a biological response. So typically that is swelling, inflammation, and a lot of pain. And that's essentially our hematoma, our soft tissue forming around it, and looking actually not only to recruit the cells necessary and the materials necessary to help rebuild the bone by bringing vasculature and blood into the region, but it also actually acts as a bit of a mechanical stabilization for the region that's suddenly very, very damaged when it comes to its structure. Of course, this is then followed by a rapid modeling response where the scaffolds are laid down in a very disorganized way to quickly stabilize that bone structure. Often this is this fibrocartilage tissue, callus formation, which is low undermineralized tissue, which we can sometimes see on images, which is then followed, of course, by bone remodeling in order to create what should be hopefully a very similar structure to what you originally started with, or as best as possible. And of course, the time that each of these progress really depends on the scale of the fracture itself. For say a wrist fracture, there's different time ranges that people give, but often, of course, this hematoma is immediate within a matter of days. Callus formation is a matter of weeks to months. And then this bony, I guess, remodeling that occurs is in the span of weeks to months to even a year out, we do still see this remodeling activity in response to the fracture. Of course, for a larger region, there's a lot longer of a timeline. Now, a reason we're interested in digital silver radius fractures is not just because we can, I guess, scan them really conveniently, but also because they are one of the most common fracture sites that anyone experiences. This is from pediatric or adolescent populations through to, this is one of the most common osteoporotic fracture sites. So we see it across the lifespan, and it happens very, very often. And even though it is generally, I guess, low consequence in the scheme of things, there still can be complications. So here, oh yeah, I'm glad we got the lights down. Here's an example. This would be one where there's actually a hairline or a very light faint fracture here that you can hardly see because it has essentially healed or is healing normally. Whereas here, this is essentially a malunion. This is not what you would want to have when it comes to a fracture formation or fracture over the span of a couple months later. Although in this case, this example, or in many examples, the most common approach to healing a fracture is simply immobilizing it, either with a cast or a splint these days, in order to allow the bone to take on its natural process. The only problem is this isn't very specific. Most people get a cast for 5 to 6 weeks. If on the radiograph it looks okay, which is really hard to see when you often can't even see the fracture, it's taken off and they go about their day-to-day life after that. So there could be a lot more tuning or improvement to this approach, or really identifying and understanding who's at risk of potentially going along this path rather than this path before it's too late and before surgical intervention, for instance, is required. So this is where HRPQ-CT comes in. I suppose most of you are probably familiar with this. I'm sure you've gotten a few talks about HRPQ-CT, so I won't talk too much about it. But one area that's been really interesting is to look at fracture healing over time. So here's an example just from my PhD, working with Phil Stanswick, who led this work, of a distal radius fracture over the span of the 3 months that we initially followed it. Where here, this is actually the contralateral side. So we didn't know this person was fracturing, of course, but that's what it would supposedly look like. And it's mirrored here just to give that resemblance. And here we see our different time points of fracture healing. So I think this is a 2-week time point, 6 weeks, and then 3 months. And you can immediately see on the 3D architecture how quickly it actually changes and repairs itself over time, which is very, very impressive. And also what's really interesting is you do see this person has what seems to be quite a lot of fragments and fracture, but they were put in a cast, they healed normally, they were sent about their day afterwards. But what we do notice quite often, which is quite remarkable, is that, is that at 6 to 8 week time point, where we actually take off their cast, is where we do see actually the most, visually at least, the most amount of callus present at that time. It's far from actually healed, and really it's just in the middle of its process. So it's really not until 3 months or further out that you do see fully mineralized bone structure actually be put in place and repaired. And in this instance as well, we do see quite a lot of change from what we would want to what we do get, which I'll get into over the study. So just to kind of give a bit of a frame the stage a bit too, is we're not the only ones that have studied this. I was helping with a fracture healing cohort here in Calgary. There's quite a number of different groups have looked into it because it's interesting. And time and time again, more often than not, we do have, of course, our standard toolkit. We use this to actually quantify our bone microarchitecture. And a big thing that has been noticed with fracture healing is it's hugely variable. So it's really difficult to interpret individual outcomes because our morphological measures simply don't really work for these really atypical structures. So just for an example, these are the most common ones that people have kind of honed in on simply because they actually in some way intuitively make sense. But here we look at bone volume fraction in the scan region or in the fracture zone. Here, this is bone mineral density, and here is our stiffness from finite element modeling. And one thing you can see is that on a group level, we do see overall trends. We do see, for instance, stiffness from baseline, so time of fracture through to, I believe this is 12 weeks out. We see stiffness increase over time, which makes sense. But the individual level is highly variable where they are. And this would be the change or the change from relative difference here. Same with BMD, we do see some people are very high, very low, and bone volume fracturing. So outcomes are all over the place. And a lot of the times this actually doesn't get accounted. You think maybe age, sex, you name it, physical activity levels would potentially account for this, but generally it's very difficult to tease out what is determining whether someone's at the upper or lower end of these outcomes. So when I got to Ralph's lab in ETH, one thing that I thought might be interesting to actually explore is looking at this local changes and these morphological measures that they typically implement in their preclinical models and apply it to the clinical world to see if we can actually get more information about bone turnover rather than bone volume fraction or bone mineral density. And so here, this is the figure I had shown before, where in this case, what we do is we take, say, a mouse tail with pins. We can actually simulate mechanical loads on it over different time points. So for the case of mice, once a week, we scan this vertebra, and we can then actually identify regions of bone formation and resorption at the local voxel level or individual levels, essentially getting information about the cellular activity. And so this is what we perform in animal models. And the thought was to actually implement this and apply it into humans. And so the first thing we had to do is we actually did, I won't go into the details of it, but we did perform a validation study to look at understanding how you translate this from a 10 micron resolution scan of a mouse model to a human at 61 microns. There's a bit of image processing that, of course, needs to be done to get that to work. But effectively, the concept is still the same, where we can look at formation and resorption sites across the bone in a human. So to do this, when it comes to the actual fracture healing cohort, I had 26 individuals, fortunately, most of which were initiated in the study and data captured when I arrived. So it's quite a long time to get these people through the process. But 26 individuals, a very wide age range, so 18 to 79 years of age, which is a bit difficult to work with. More females than males. All of them, however, were conservatively treated fractures. So all treated with the same protocol, 5 weeks over there of cast fixation and a fiberglass cast, which was then removed. And this is sort of the step or data collection that we did perform. So after the fracture, they came in at 1 week, 3 weeks, and then they had the cast mode taken off right before our 5-week scan. And then they were spaced out more at 3 months, 6 months, and a year. And in these later time points, when they had their cast removed, we did collect functional outcomes. So PRWE, so patient wrist something score, that quick dash, I believe, was collected, as well as things like grip strength, range of motion. And then alongside this, I won't talk about it too much, but we did collect bone turnover marks at every single time point here as well to look at essentially whether we have any indication of formation and resorption with those markers. So when it came to the imaging protocol, we used HRPQ-CT. In this case, the one stack is not quite large enough to really get the information we want, especially because of the variability of fractures. So in this case, we actually did the 3-stack protocol where we captured almost, I guess, the mid-distal end plate downwards. We collected about 30 millimeters, so 3 centimeters. So still not that big, but enough to generally get the full fracture and some actually. So downwards here, there would be no fracture zone. It's always kind of in this region. So we got that information from all of them. And then to actually collect that information on dynamic morphometry, so where we see formation and resorption. I'm just going to talk a bit about how that process is done without going into the precision work we did. But here, for instance, we have a baseline and a follow-up image of an individual actually that did fracture. So this is an exaggeration, so you can tell the difference. But here you see there's sort of this gap, or this is an odd angle, but there's a fracture zone here, and it has healed over time. So what we would do to look at changes at the voxel level is essentially zoom in and take that region, and we can see this essentially when we align them, of course, and register them pixel by pixel, we can actually subtract these and identify differences in the images. And so, of course, you get something like this where I've labeled them by color to make it a little more evident. But of course, where you have a decline in VMD, you can identify that difference. Where you have an increase, you can identify that difference. And the big thing is to decide what is your cutoff effectively to determine what is real versus what is simply noise in the image. And so that's some of the work we did. We identified a cutoff point that would be considered true change versus just measurement error in order to determine essentially formation sites and resorption sites. And so what we can do with this is then get over the whole bone structure, essentially a ratio. So we call it bone formation rate or bone resorption rate, which is just the volume newly formed of the total bone, or vice versa, volume resorbed of the total bone. Now, of course, it sounds great. That's sort of where I started off when I did my postdoc, but immediately we ran into issues with this method that were not present, of course, in the mouse models. And one is there is movement, and these are larger scans. So one issue we did come across is with the HRPQ-CT image, because we're doing that 3-stack region, we do get these little slices or motion artifacts, or we call them stack shift artifacts, but they're effectively just slight motion that's inherent that you can't get rid of. And so this causes a lot of issues, as you can see. For instance, this is one of those images. This is what you would get in the scan, but in reality, the alignment of the bone is actually a lot more like this. And it actually is quite a big difference, even though, and for these individuals, because we were scanning them with a cast on, they had a lot more free motion in the scanner, meaning that this is a lot more, they're a lot more prone to having this artifact than you would scan in a typical healthy individual that was properly fixed in the scanner holder. So this results in quite a few issues. Here's an example of just 2 stacks. And you can see this really stark line of remodeling sites here that are clearly not actually physiologically possible, that we had to sort of resolve. And so much of my time was actually spent figuring out how do we properly align these scans without oversampling our images and inducing more artifacts. And so feel free to ask me questions about this process, but I'll go to a little higher level because I know this is the HPL seminar and not the nice mathematical formulation seminar. But essentially what we did is we took these scans and we treated each and every one of those stacks as its own individual image, registered and aligned them together one at a time. And what we could do then is we could treat each one of those little alignments or registered images and superimpose them to create an even bigger image here. So for instance, I line this slice to here, and then I can actually superimpose them or add them together to create an even bigger region. And so what I can do with this is now when there's gaps between the scans, by using the information from additional time points, I can actually bring that together, fill in those gaps, so that I can actually align the bone in each scan all together. And then that gives us some information on improving that alignment and that information, that structure effectively. Now, the big thing is here I've done, 1, 2, and then probably 3, 4 multiple transformations. If you work in image processing, you don't want to constantly transform and register your image because you're going to degrade it with interpolation artifacts and all that. So instead of actually applying this to the scan, once we run this and get all our transforms, we can actually store this in what's called a graph model and effectively just compute what the full transform would be by following this little map and adding them to concatenating them together. So then we effectively only apply one transformation on the image that perfectly aligns it across all time points. And so just visually to show what that would look like, say you have this scan, you have those little notch artifacts that you can see. We separate that into its stacks. We use that graph model to calculate and compute our complete transformation we have to do to properly align the scan like it is now. And then one issue is we have all those holes in the image still. So we properly align them with massive gaps, which cause issues, of course, for inferring or understanding what the bone structure looks like. So we can actually fill that information from other time points just to fill in the bone to understand what it should look like. Now, of course, we don't use this for any actual analysis, except for finite element analysis, for instance, and more visualizing and looking at the bone structure. So we can fill it with the most recent time points, which we have lots of. A 6 time point scan study is a lot. And then where we still are lacking information, we can synthetically fill that with some dilation kernels. And we put some restrictions on this, of course, to limit only tiny holes can be filled. Otherwise, it gets a little, you're sort of hand waving there. So once we kind of overcame this challenge and resolved the issue of aligning these stacks and these artifacts, we actually could get some really beautiful images. Where here, this was what we had before, this challenge or this issue. Now we can actually kind of completely omit it and we get some inherent noise. So this is actually a scan that is a same day scan. So everything you do see is artifact, but it's dramatically reduced from what it was with the stack shift errors. So now we have a protocol that actually could work in humans. And the goal was to now apply it to those fracture healing study. And so when we do, keeping in mind this is sort of our baseline error rate that we do see, we actually get quite amazing images when it comes to dynamic morphology. So here's just one individual fracture with a fracture healing over time, where we did pick an extreme example so you can see how much is going on quite nicely. Most of them do have all this activity inside. This individual, though, does have an external callus, which was not like the norm, I would say, in this cohort, but it does show that sort of dramatic sun formation that's occurring, low mineralized tissue, which is then being resorbed and remodeled over time. And you can actually see here, these are sort of the interpolations that we sort of ignore or do come from it, but otherwise on the whole, we can actually capture and quantify just how much remodeling activity there is over time. And so here I'm also showing the whole group. So here's our population from the study, where you see early on the remodeling, the formation and resorption rates early on are of course very, very high. These are normalized to rate per week, because of course we have different step intervals between our scans. But you can see how they sort of stay quite elevated between weeks 1 to 3, and then quickly start to drop down and stabilize too. This sort of level here would be quite what you'd see in an individual over the span of a year. So quite low levels again. So it does calm down and plateau quite quickly. One thing we did also find interesting was that we actually have, on a net level, only at the start, we do see actually this significant, I didn't mark it, I apologize, but significant dip of net bone formation rate, whereas the rest are actually quite balanced. And so this net remodeling rate is essentially the ratio between formation and resorption that you see. And yeah, so typically you would expect this in a healthy individual, of course, to be relatively balanced. You have just as much bone resorbed as you had formed. In fracture healing, one interesting thing is we would have expected actually to see more formation early on than resorption, but we did actually note that it was a negative bounce in these first few weeks. And more so, what was interesting is we did actually find that this net remodeling rate, although a really low imbalance, so only 0.8% per week, that's quite little, it was actually quite associated with your final outcomes. So, and final outcomes, what we use here, for instance, was total BMD, so total bone mineral density at 6 months out after healing. We found that the more imbalanced you were here, the lower your bone mineral density was of the scan region 6 months after your fracture. So that was an early indicator of what perhaps might be a determinant of fracture healing. Of course, though, BMD might not necessarily be the outcome measure of choice. It's a bit unclear whether that's the right measure, but that was an interesting finding. What was interesting, though, was we also didn't find, for instance, individual formation or resorption rate to be associated whatsoever with outcomes. So in essence, it was the balance, not the necessarily magnitude of either of them. So actually, that was the initial study design and the plan. But one thing that did come up, especially when looking at that stack shift artifact, sorry, we looked at a lot of images. So I was visually inspecting essentially every person, every scan, every time point. And one thing that I noted when doing this was actually that over time, a lot of people experienced a significant bone loss. So this is a male, middle-aged, and you see that they actually have quite an intact architecture. Their fracture is actually up here. And over time, one thing we noticed was we suddenly get this huge amount of structural loss. And often in cases that seem to be actually quite far away from the fracture site itself. And this occurred even in individuals, say this is a 29-year-old female. You can see a substantial fracture here. And as you follow it, you don't notice this callus formation, so this remodeling activity up here. But when you compare the first and last time point, so this is a year out, you actually see this huge void region that appears. And often, quite often actually, this seemed to appear more typically later on, not necessarily at the very beginning. So for me, I thought that was quite interesting and not what you would expect to see, and not really something that is often reported or discussed in the literature when it comes to concerns about fracture outcomes. And this tied back a lot to my PhD research, where I essentially developed an algorithm, a morphological algorithm, to quantify what I call void spaces in bone microarchitecture. This was more to characterize and understand osteoporotic bone. So here's an example of an older, I believe an older woman. And this would be the measure of essentially regions where you have deterioration of the architecture to an extent that would presumably not be repairable on its own, at least without some sort of intervention. And so this would be a protocol that I thought perhaps this could be help to sort of use and quantify this observation that we did see, we agreed was there, but only qualitatively so far. So yeah, the question was, do these develop? Is that a concern? Especially for those, particularly for those younger individuals. So middle-aged men and women who are not considered osteoporotic at this time. So just briefly, I'm just showing this. This is the algorithm for it. I'm not going to kind of go in detail of the steps there, but the idea is you essentially extract and segment this region and quantify it as a volume fraction of void space relative to total bone volume. And so this was previously established with healthy bone, but not yet applied to fractured bone. And so the idea was essentially to apply it to these structures, like shown here, where you would then get these little regions wherever they may be across the bone and be able to quantify them as a ratio. Now, the big thing I wanted to look at was simply just looking at the first and last time point to see if there was a difference that did exist more consistently across the population. And so when we do perform that, and it's not surprising because we did see it and observe it, we actually do see quite a significant increase, at least on average, from the last available time point, to the first, available time point to the last one, of void space increasing in these individuals. And this is quite a substantial, this is a sort of a, tip on the median is near 0, about 1 or 2% in the population, up to about 8%. And that's quite a large jump for only a 1-year span of the study. In some cases, actually, we only had up to 6 months. So that's quite a substantial amount of bone loss. What was very interesting as well, though, is with these same individuals, we actually saw on a group average, no significant difference in bone volume fraction or bone mineral density. Although the individuals themselves were quite scattered and all over the place, on a group level, generally, the net amount of bone that was present at the start remained in that scan region at the end. So with this information, it essentially gave the story to me that there is structural reorganization of the bone that's happening. So preservation of mass, but an organization that might potentially be quite detrimental. And so one thing, though, that we did notice, was that these void spaces didn't necessarily occur in everyone. And of course, just like all the other outcomes I really talked about, the individual trajectories, which now I show here for all those people, were very spread. Some people developed very large ones. Other people actually managed to avoid it and stay low and stay maintain their bone structure altogether. So the big question was, okay, how do we actually quantify this over time and track it? Because one challenge really is we have these void spaces disappearing or appearing, I suppose, the ones that we're trying to measure. But at the same time, we also have, at the very beginning, we of course have fractured bone that hasn't yet formed a callus. So we have these large holes that appeared either because of the fracture itself, or potentially the person had a void or something there before. And so the big question is, we need which ones are manifesting or forming because of the fracture versus what was pre-existing and the individual already had. And so this is where I sort of decided, okay, I need another approach. I need to do some more computational analysis to distinguish what is old void versus new void. And so to do this, I developed another quick algorithm to essentially assess and distinguish between void space expansion versus void space contraction. And so this is just a visual schematic, very, very similar. The concept is actually motivated by the bone formation and resorption rate, where say I have this, hopefully you can see it, the gray segmentation is the void that we see. This is just simulated here, where say if it expands like this, where we have a huge jump in that bone, what we can do is just like the morphological analysis, we can subtract the two to identify regions of bone formation or void space formation, what I'd call expansion. On the flip side, if that void space gets smaller in that region, then spatially we can subtract that data and get information on where that void space contracts. And so what this means is that we can essentially distinguish what void space is appearing versus what was there before and is actually being filled by fracture healing like it should be. And so when we apply to those bones events, those scans, we actually get a very dramatic story, which I think is very, very interesting. So here is just an example that I think the same individual I'd shown before. This is the 29-year-old woman, where we see at this time point, so this would be 2 time points, week 1 and 2 overlaid. And this purple means that there was a void there and it's been filled between those 2 time points. So that makes sense. We had a fracture, there's a hole. Over that span of time, callus filled it in and started to create bone. Then we start to see new holes or gaps appear, these voids. And then they seem to suddenly get a lot more larger, quite dramatically so, and concerningly completely outside that fracture region. We do see some fluctuation here, which perhaps is that callus reorganizing, restructuring. And we do actually see that over time disappear. Whereas down more proximal, we actually have this void space stabilize and coalesce to the point where it's not going anywhere after 1 year of time, effectively there permanently. And when we look at the whole population, we do see where I've distinguished void space expansion rate versus recovery rate. We do see at the time, that 5 to 12 week period when we take off that cast, or 5-week period, we take that cast, we see that this is actually the biggest peak in time where we have this void space form. Whereas when it comes to the void space recovered or contracted, most of this is happening early on when you have that callus form. So this is a delayed or a later stage response of fracture healing that really hasn't been described to my knowledge in the literature, other than systemic bone loss after fracture perhaps, but this local loss is not really identified. And so the big question is, especially at this time point where we see this huge surge in bone loss, especially structural bone loss, the question is, can anything tell us about it what is it associated with? So we went and took a look at the information we did have. We had bone turnover markers, like I mentioned, so resorption information. And then we had the clinical assessment measures. So grip strength, range of motion, and PRWE. Range of motion, there's a bunch of different metrics, so we didn't analyze each and every one of those in detail, but we did do grip strength, PRWE, which I didn't include in this presentation, but and then of course the individual resorption information markers. And so we looked at the time point where we have this high incident of this void space expansion to see what was associated with it. And interesting, what we found is, somewhat surprisingly, none of the bone turnover markers were associated. PRWE was not either, but grip strength was, and quite notably so, even in men and women. Here I'm showing the absolute grip strength, but we also did check this out, of course, with relative grip strength. So comparing it to your healthy side, the same correlation exists to the same strength. And we do find that essentially, the higher your grip strength, the less void space you develop at the end, this stage at least, and of course, continuing on to the end stage of your fracture. Whereas if at the time or shortly after the time your cast is taken off, if your grip strength is really low and really weak, you are an individual that is going to be very, very likely developing these structural bone losses. And this is actually quite an interesting question because we didn't have much prior information on grip strength. We didn't study this in detail as an intervention, for instance. This was just observational. So a couple of things we really don't know is what's the cause versus correlation? And so one big question is grip strength an indicator of healing progression? So if someone's not able to grip and lift things up after they've taken their cast off, is that because it's painful and it means that the fracture is not sufficiently healed so that we're taking the cast off too early? Or is it the other way around, where if someone's not using their hand and not inducing that mechanical load, are they actually now causing the bone to be more further resorbed and have a higher consequence? And so with the information we have, it's too difficult to tease out, and the interpretation would be relatively dramatic, different decision-making when it comes to cast time and recovery intervention. But it has led to a lot of questions about, okay, what does this mean and what should we do about it? Because something like grip strength is something we can easily assess and potentially influence or impact. Yeah, and so as I sort of close out, the last little thought is I haven't discussed finite element analysis on these. It's a bit of a difficult analysis to do because we don't have the full bone structure, so we might not actually be accurately representing the forces and I guess the biomechanics of the bone. But just initially looking at it and postulating some questions, the reason why void space might appear, there's a few different possibilities that we've discussed. The main one, I think, that has more often honed in on or not, is this idea of stress shielding. That's often discussed when it comes to orthopedic surgery, when you put metal implants in. But in this case, what we do think is perhaps essentially the reorganization of your bone structure does lead to a different mechanical environment, which then, and of course, this is compromised mechanically in here, which could mean that the bone is adapting and responding to that, where the lowest priority bone is being resorbed for the sake of supporting and strengthening where it needs to in order to function. So that could be a possibility. One could simply be a deficit in disuse after the cast has come off, meaning that even perfectly good bone that is mechanically important is being resorbed. Another one could be that on these scans, we actually aren't seeing the full extent of the damage. And so that could mean maybe this bone microarchitecture is in some way, micro cracks are in there, or some other deterioration has happened. For instance, vascular damage could have occurred. And so that could be making an effectively necrotic zone that's being resorbed. So lots of questions. We don't really know the answer, but that's the idea of kind of exploring this further and building off these insights. So with that, I'll kind of conclude and just summarize that, yeah, this is sort of a bit of an incidental finding from an initial study design, but one that I think is actually very interesting and worth exploring further, not only for distal radius fractures, but fracture healing in general in the population. Yeah, and I, of course, would like to very much thank the individuals involved and who supported this and all the funding sources, and welcome any questions.
Right. And
I was just wondering for your grip strength measure, did you check their contralateral hand too? Were they both low or?
Yeah, sorry. So I did forget to update that slide because we did, of course, do, so it was an average of 3 measures actually. So that was the plotted values there. And then they did do the contralateral side. And so when we do the ratio, the same correlation exists. Essentially, if you have a weaker fractured side than your non-fractured side, that is the same as the absolute grip strength. But yeah. So.
But were they?
Oh, were the people
lower
weaker?
like if you just looked at the contralateral grip strength, did that inform that
So we
relationship as
didn't
well?
look at that, but I can tell you that because of our cohort, we do have the males inherently have higher grip strengths.
Yeah.
And so we would probably inherently see some of that association. I don't know if you actually limited to just women. I don't know. I don't expect you would see it because, for instance, we looked at age as an example. Age is likely correlated with grip strength too. And that did not associate with void space forming. So that 29-year-old woman versus the 85-year-old man, we couldn't distinguish those differences. So
Just to build on Andrew's question, did you look at it in terms of any sort of like body mass normalized strength or mass normalized strength? Or was it just the absolute?
no, so we have absolute and then just relative grip strength. We didn't adjust for body mass or anything like that. I mean, it's not a weight-bearing site either. So the amount of mechanical stimuli on that site might not necessarily relate to your body mass, but I could be wrong there.
How might these variables be confounded by fracture severity?
Yeah, so probably quite a bit. Another thing is actually also one thing that I think confounds it just as much, or if not more, is the fact that we had a hugely heterogeneous population. This is one of those classic things where you start collecting data and then the study design sort of extends and seeps. So we had individuals age 18 to, I think, what was it, 70 or 80 years of age. Their baseline bone turnover markers are very different if you look at an 18-year-old female versus an 80-year-old male or 80-year-old female even. So that also was a difficult confounder that we couldn't, we just didn't have the power to even adjust for. When it comes to severity, we do think that these markers would associate with fracture severity, but the fact that we did look at these relative to, say, that bone turnover rate, and it was really difficult to tease out meaningful correlations without just simply doing a, p hacking and fishing for associations essentially.
Did you have some kind of
severity measure?
I mean, it'd be great if you like had a really cool, fracture energy based measurement
Yes.
or something. But I mean, I assume they sort of radiologists grade the severity of these.
Yeah, so they have classifications. This is one thing, yeah, we'd have to actually go and look back at those classifications and then actually rank them on what is severe.
Okay.
All these individuals, though, were at the standard treatment of care. They were not severe enough that they required surgery or did go on to surgery. So they're all in the same low severity group. But yeah, within that, you have different fracture classifications. So that would be worth looking at. Again, there's more classifications, or as many almost classifications as there are males, for instance. So it's a bit difficult to account for these in this type of study. You'd have to actually narrow the study design for sure. Yeah.
And then
Thanks, Danielle. You've obviously alluded to the body size influence on
Yeah.
grip strength, but it is sort of interesting that the women were more likely to form more void space.
Yeah.
Can you tell us if they're peri or postmenopausal? Because there's obviously some differences, presumably, and maybe what that might, how that change in status and a hormone might influence hormonal.
Yeah. So again, it gets really. We didn't have that many postmenopausal. I don't know if we had distinguished perimenopausal, but we didn't have that many women that were that old. And just kind of going back to this example, one of the more severe cases of this void space forming was in a younger woman. So that association, at least with this sample size, was not evident. That sort of age association, we couldn't do all these sub-analyses looking at body mass, menopause status, all this stuff.
And
so we
you wouldn't
couldn't.
know if she was pregnant.
They definitely were not pregnant. Yeah, they would have been excluded
or
from the
had a
study.
pregnancy.
No, they wouldn't. They would have been excluded from the study if they did, unless she was lying or something. But no.
Well, yeah, she wouldn't be pregnant during the scan, but
No.
if she had had a previous pregnancy.
Oh yeah,
Like-
we don't have prior pregnancy
Yeah.
information. No. Yeah. Sorry.
I'm glad you're not radiating.
Yeah, no, we definitely did not.
Yeah, no.
They also collected DEXA scans at like
Yeah.
month 3. So like, yeah, we would have been in big trouble if they were, any of them were pregnant. But none of them were on confounding medications at the time. That was a criteria. So no no medications or diseases impacting bone turnover. But yeah, prior pregnancy definitely not included. Yeah. Lots of questions, of course.
So my question is, what's the relationship between void space and mechanics?
Yeah.
And the reason I ask is because I usually see imaging talks and people are doing all sorts of finite elements and calculating all sorts of things. And I think you showed some stiffness early on.
Yeah.
And I can't recall whether you showed it later, but presumably all the finite elements and stuff is helpful. And so is void space a proxy for mechanics, or is it better? Or is it just something that's not interesting, or sorry, is mechanics not interesting compared to void space?
Yeah, so for me, both are. And yeah, so I did not do a finite element analysis, although it could be a quick slap on and add it to this study. I did not perform it largely because, although a lot of studies have done it, one challenge is simulating the true mechanical environment. So here's just an example of like a demo one, where we have this cutoff of the bone. We don't have the true bone surface. So we just apply an axial load and get these this distribution of our strains or strain energy density or whatever is here, effective strain. And so, but when we do that with a site that is clearly like is fractured and that fracture actually extends up here, I am wary that performing that sort of analysis here is not going to give you the true information on the mechanical environment. So I have avoided it, but I don't know if we would have, I am curious to see in like future studies, if we do see an association between our recovered stiffness, for instance, and our void spaces that do develop. There may very well be a relationship. One possible thing could be that these changes, of course, are compensating for this void space being formed. So it may be that we don't see a relationship at all in the short term. But to me, what's interesting is when I look at mechanics, when it looks at your distribution of effective strain or your failure load that we estimate, it tells you the bone state now. It doesn't tell you the bone state in 10, 15, 20 years. Something like a rate of bone loss in response to a fracture event, for me, actually is quite a lot more interesting because it tells you a bit about the metabolic state of that individual or the bone's ability to respond and adapt. And so that might actually give you a lot more information about long-term bone quality versus something like failure load, which gives present day. That's sort of a personal take, though.
Hey, Art, Brent, and then Maurizio. Oh, sorry, no, Rash.
Okay. Okay. Looking at this picture specifically, or the picture before that, before this case, the thing that I think is probably happening, maybe, is that the musculature that is bending the bone, the cortical side of the bone, sort of, is weaker after the fracture versus before that. That might be the reason. So you have less bending in one side.
Like here.
If you have the musculature there, then you have less bending in that side, and then it would technically wouldn't need that much of strength there, because there's no strength.
It's not used,
there, right? Did you try to look at the asymmetry in the flexion extension?
We haven't actually, but that would be, we have that range of motion information we do have. So that's something we could actually look into to see if, there is a relationship between the range of motion and well, here we don't have this information for everyone, but we have the void space information and bone loss overall. That's a good point, because that would give you an information about atypical, I guess, mechanics being applied to the bone after healing. Yeah, that's a good point. Yeah, but we haven't yet.
Follow up, and because I had a similar question. My question was, did you look at muscles in general following casting for 5 weeks? Because muscles being created there and not really being used. There's a lot of potential for fat infiltration, fibrosis, and other things. And maybe where you get those things that Arash was just alluding to, might have not so much to do with the bone, but might have to do with the muscles and how well or not well
they are,
the muscles, dealt with the 5 weeks of not doing anything.
That's a good point. Yeah. So of course, as most of the other questions of did I look into this or that are probably going to be no. I do apologize, but that is a very good point. And I don't know what information we can accurately get from HR. The only scans we have are HRPQ CT. And then of course, what we have is grip, clinical measures, so grip strength, range of motion. But it is a good point, looking at muscle, essentially that like loss, either cross-sectional muscle area or fat infiltration, could be quite informative, even ahead of seeing the void space loss, seeing if they are actually losing that before the cast comes off. It's a really good point. I think that could actually be very informative. But I don't have the answers, of course.
I'm not sure, convexa, can you get anything about muscles from DEXA? When we,
Lean mass.
You get
the
lean
right
mass.
arm.
Yeah,
Or no, that's
but
fine.
not really muscle quality like they do with,
no.
You could, if
So,
you
yeah.
had like, if you had like PQCT, you could get.
Maybe get
but
it,
you
yeah.
need to get the muscle belly.
Yeah, that's the hard part. These scans, of course, are like right here, so, but something like even, yeah, if you were, for instance, to use MRI to do that, you could actually get some of that information of the whole bone pretty quickly. Just, it's a bit expensive. But yeah.
This is all along the same lines, but I'd like to entertain the idea that bone could in theory be lost for non-mechanical reasons.
Yeah.
So how characteristic was it that every time you have these void spaces being expanded, that they're quite sort of proximal and they're close to the marrow space?
Yeah.
Because they always looked to me
Yeah.
like they're there.
Yeah, they were, it was 100% of scans, I would say, had this, well, of course, not all of them had the void space appear, but having the void space expand and manifest in this region was quite characteristic. If it was going to, it would appear here. Sometimes you'd get voids up here, but this was the notable finding.
I wonder,
Yeah.
you have all the osteoclast precursors in the marrow, right? And then you have cellular migration, and you have to get stuff up to, so I don't know where the cells come from.
Yeah.
I mean, there's vasculature and stuff like that, but I'd like to, like maybe it's happens that there's some osteoclast cell migration from the marrow space. And
that's what we were, yeah, so that is a thought. And one thing is just knowing how to measure that was a bit difficult. Like that's why we did look at these associations with bone turnover markers, thinking that maybe we'd see a surge in CTX and this is related. Now we only did this at this one time point. Maybe we need to look at a temporal effect, so an offset of what time point of bone turnover marker we look at with the void space. We didn't see it clearly, but I don't think that's necessarily because that couldn't be the case. I think that's because the bone turnover markers, these are systemic measures that might not reflect the local activity. Because you're not seeing bone loss at this scale on the contralateral side. We scan that at multiple time points. It's steady. So yeah, it is a very good point. And I think there is a surge, there is a potentially, especially with this sort of, females clearly having a lot more void space appearing, even though it is very associated with grip strength, there could be actual like hormonal or metabolic responses that are causing it. Lots of questions.
one quick,
Yeah.
very quick,
Brent,
not really
Brent,
important. but
Ashna, then we'll-
And I probably don't understand the algorithm. Before you talked about the void space, you talked about the formation and the resorption, you do the fancy registration.
Yeah.
But in my mind, you could have this fracture, shoot through the trabeculae, and now you have a void space.
Yeah.
And your algorithm wants to call that resorption, even though it's really just void space.
Well, we
Where
don't
the
have.
bone has just kind of moved, you know what I mean?
Yeah, we don't have it before, we don't have a scan before the fracture. So we only have the scan
Oh.
from, obviously from after fracture. So we have it exist already, and then we can watch it essentially repair and model. So we have it 1 week after fracture. Usually there's not much visible, if any, callus forming yet, at least detectable from the eye. Then it starts to appear, and then you see this void space appear sort of subsequently. So yeah,
Of
so
course you don't have it.
yeah, if only.
But that would be nice. Yeah.
Yeah, it would be helpful.
All right, so Maurizio first, waiting along, then Ashna, then Walter.
Okay. My question is related with the rehabilitation process. So did they receive sort of kind of physical therapies rehabilitation? And
Yeah.
my second question is related with the same. Did you mention about the quick touch score, no?
The quick dash, yeah.
Yeah. So
I think
it
they got
was-
something along those lines, yeah.
Okay. It was any similarity with that grip strain relation as well?
I didn't pull that data. This was all, so they collected a lot of information, and I pulled because PRWE was one that was found to be associated with stiffness, I pulled that one just because you can there's pull 50 parameters, find an association, call it a day. I pulled PRWE because it was associated in our past studies and other studies with stiffness measures. I didn't look at Quick Dash. I believe they had it, but it wasn't calculated or whatnot. So I would have had to done that. Same with range of motion scores and all that. So I didn't look at those specifically. And what was you had probably
About the rehabilitation, the process of rehabilitation.
Yeah, so in theory, actually, these individuals were supposed to do at-home exercises after their cast had come off. There was some self-reported compliance to that, and it was quite scattered and inconsistent. But these people, as part of just, I believe it's standard of care, but these individuals were going through the study at an osteoporosis clinic, so it was more, I guess, involved. So they likely were doing potentially more rehabilitation, but it was really inconsistent whether people were actually adhering to it or reporting what they did and all that. But they were supposed to be they were given instructions for at-home physio to recover their bone.
I am mentioning that because in clinic setting, we use the grip strain as an indicator of success of rehabilitation process.
Oh, okay.
So that is the most useful tool that we have, and it's a really good relationship with the age as well.
Yeah.
So we have some data that normalize the population, worldwide population, so we can achieve that number that we are looking for with the rehabilitation process. So maybe there is something that explains that relationship with the grip strain.
Yeah.
Related with the exercise they start to do after they start to the movement, because it's really that point that when they stop the immobilization process, they start to show up that loss of tone. So
one thing, so I do agree. Like, I think the understanding, and it's a good point that maybe people that did exercise or do physical activity before are more likely to do rehab. One thing we don't know though is if the void space is appearing because that's when we take off the cast and they're off, or if it's just that's a coincidence that's the time, because that is also the time point when we do actually see the peak amount of callus form and all that. So it is a physiologically relevant stage and also clinically relevant. So you'd actually have to do some sort of varying intervention to see if there's actually a relationship with that time point with void space development, or that time point in clinical care. Yeah.
The slide you were on previously had those two questions where you mentioned that, yeah, exactly those. That is the fracture still unstable, or if the cast is coming off too late?
Yeah.
Did the cast come off at the same time for everyone? That
Yeah.
5 week mark?
5 weeks, probably give or take some days, of course, for scheduling, but it was standard care that they were receiving. So it came off. They got a radiograph to make sure that it's, the clinician considers it fully healed or sufficiently healed, and then they continued on. But yeah, there was no one had dropped out from this study because it was quite restrictive, the inclusion criteria. No one dropped out because of needing to extend that by the clinical decision making, or had to go progress to surgery, which could happen in the more typical population.
I'm wondering if that second question can be answered using your data set, because you're imaging them quite regularly, right? And following them. And so did you ever notice that there's people who would clinically, based on imaging, be passed off as someone that can now take the cast off and have recovered, and we're still waiting for that 5 week mark, and so maybe that part of the question is answerable?
Yeah, it's definitely the case. So I think there's enough data to propose an actual intervention where you would make the decision based off the image data you have. But that hasn't actually been implemented in a study before. All of the studies to date have always followed their standard care, where it's thought somewhere between 5 and 6 weeks they take off the cast. So it is a really, with the data we have, we could infer, okay, when you see that peak callus formation, that's when the cast should come off, because that's the typical. But it's really hard to decide what the peak is for someone without seeing it go down after. So it's a bit of a challenge to really make those decisions. But I think doing a varying sort of cast removal sort of study would actually be really interesting and beneficial if you did it based on a measure like grip strength, for instance.
Even like a follow-up analysis using the same data set, like you can take a look at the different images and then say, we divide the group into two kinds of people that the cast came off very close to when the callus formation was met.
Yeah.
And then for the ones that it came off, it started going down. Did you see that being related in any way to the grip strength, that people that came off close to their healing,
their peak time,
didn't decline so much?
That's a good point. Yeah, you could risk this. You could take a look at that, actually. I'm curious. It's always hard with the heterogeneous populations, but it's a good point. The same with, of course, the muscle atrophy and all that too. Interesting.
I just wanted to follow up on
Yeah.
what Brent said, which I thought was interesting, you know, that maybe there's nothing to do with mechanical loading,
Yeah.
fracture healing and things. I want to argue the other way around. What if it has to do not with fracture healing, but all with mechanical loading? So the question really is, has anybody, you or anybody, put a person for 5 weeks into a cast that didn't have a fracture and then see what happens to the bones? You know, like, do you get those holes as well, or?
So I haven't, of course, we haven't subject anyone to that at this time, but with bed rest studies, well, space flight, as Leah's plenty studied and all that, we do see bone loss. There's no doubt about it when you have complete disuse or something like that. Whether you see it in the same way observed here, it would be a big question. I don't know if you see this structural loss.
What do you think? So is it due to the fact that you just immobilized the joint and the arms and the muscles? Do you see so many changes, or is it actually due to the fracture healing?
I think it's due to fracture healing. There's a couple, well, I think it's due to fracture healing and some prior sort of demographic or characteristics of the individual. So I think it's closer to Brent, but I think the mechanical disruption of the environment is what's triggering it. Largely because we see these void spaces appear in people who have had a hip fracture. So they arise by, in older age with, something that's causing or resulting in osteoporosis that isn't necessarily like just unloading and whatnot. So metabolically, there's likely something going on, or hormonally. But here we have sort of the steady state, this individual, then we have this sudden event that's causing a disruption in the mechanical region. It's also causing a whole disruption in your vasculature, the whole cellular niche there. And so I think this is causing a bit of a feedback loop that results in this systemic bone loss to essentially compensate for the fact that there's this issue at hand. And a big reason for that, actually, that I would think that is because we do see this really inconsistent outcomes when it comes to bone volume fraction and bone mineral density. So we do have potentially, if this is a larger sample size, we likely would eventually start to see a trend towards bone loss when it comes to bone mineral density. But consistently, this doesn't clearly translate. We're not having systemic bone loss. It's bone reorganization that we're seeing. So there's something that's kind of causing that. That's not the same as just disuse. Yeah.
The other thing that I thought was interesting is when you mentioned quickly, maybe 5 weeks is too long, we should take the cast off earlier. The other thing would be, I was thinking people could do isometric contractions in the cast.
Yeah.
You could actually develop a progressive program, over the 5 weeks.
Yeah.
Do people do that at all? Because that would be fairly easy to load your bone, even though everything is constrained in the cast.
Yeah, I mean, a lot of practice is also shifted towards, if you can splint it, use a splint instead of full immobilization of the cast, because then you do have some, contraction or muscle use or hand use. But yeah, I mean, I'm not a physician, so I wouldn't know for sure what's really been put in practice, but there is more of a shift towards earlier, mechanical loading on it, regardless of these outcomes and anything like that. But there is a bit more
instruction, rehabilitation process, kind of do 10 minutes of isometric contractions every day.
Not that I know of, but it's possible that's in some practices, but not that I know of. These individuals, for instance, weren't instructed to do that until the cast was off. So, yeah.
All right. I'm interested in knowing how many of these people again get fracture and how many of those fracture actually happen
at the site.
And if we have any information about that.
No, I mean, this study, the 1 year follow-up concluded within this last calendar year for the final people. So we don't have follow-up information on them yet.
Not necessarily about this population in general,
Oh.
population with their risk fracture, and then if they have a risk fracture sort of in the same region, what happens?
Yeah.
I'm trying to think if there's no mechanical strengthening in that part of the bone, maybe the reason is because you wouldn't really need strength in that part of the bone, different boning now that you change everything. If there is need for that, and it's not there, then you would have fracture there, right?
Yeah, so there is definitely a relationship between prior fracture and future fracture, just in general. So if you've had a fracture especially a low energy fracture, you're more likely to have a future fracture. When it comes to like parsing out, I guess, especially looking at like just available data, if you look at HS and pull that information, it can be difficult to tease out the fracture, the mechanism fracture, the cause. And you don't have information like this, like not everyone developed this void space and structural bone loss, right? So those people are not going to go into fracture potentially, and maybe the ones that do get void space go into fracture. So I don't know for sure, but typically a fracture is indicative of higher risk of future fracture. Whether or not it's at that site specifically, I'm not sure if that's been looked at in detail. I think in kids it is, but I don't know. I'd have to double check. Yeah, but that would be an interesting to follow up on. That would be worthwhile.
Any other questions? Yeah.
Did you get a chance to look at the plane radiographs? Like, are those sensitive enough to also see some of this void space formation?
No, so I know I haven't, but when I give this talk to clinicians, they're like, "Oh yeah, we see that happening sometimes." You're like, "Really? You didn't talk about it?" So it is sometimes show up. Not always, but they do say they do see this, especially this loss, like kind of this characteristic loss here. They'll say like, "Oh yeah, that happens. It's just, you know, like it'll come back probably or something." I don't know. So yeah, it's kind of like, oh, okay. But so it does show up sometimes, but it's not quantified in any way. And I don't have access to the radiographs, unfortunately. So at least not now, being over here. So I can't actually go and look and see if you can measure that other than just this qualitative clinician opinion.
And from a clinical perspective, if you're seeing that in the radiograph of a patient you're seeing,
yeah,
would, from your non-clinical experience, would that change the way you think about that patient and how to manage it moving forward, or is this not something that you would include in your next step process?
Well, so studying this in detail, it would change my perspective on it. Say getting a follow-up scan with 3D imaging. From a clinical perspective, they don't have time to follow up this patient. You know, they only get typically they'll get a scan at this time, a radiograph at your 1 week or week 0, and then when the cast comes off, right? And they look at that. They don't necessarily, they compare it, but they're looking at the fracture itself. And if that's good enough, then their job is done, right? So they're not typically following up. If you have a really proactive physician at the time of fracture, they're probably going to say, you should go get a DEXA scan, look and see if you have osteoporosis, blah, blah, blah. Often that won't happen with a wrist fracture, but it hopefully should trigger it, but they simply don't have the time, and that's maybe not their focus or expertise, especially we're talking about like orthopedic surgeons or emergency medicine versus an endocrinologist. They're thinking about different things with this care. So, yeah.
Okay. Also, do we know anything about OA, risk following a fracture, following a radial fracture?
I don't know anything. I don't know if anyone else, but like, yeah, essentially, do you develop this or progress it? I'm not sure. Yeah. I mean, if you have it at that higher, you know, the end plate and all that, I could imagine it would result in something. But for the studies I've done, of course, they have been non-surgical and not so complicated. So usually, you know, closed, reduced fractures. I imagine you're going to see that more in fractures where it's much more severe, much more disruption, maybe change in length and all that requires surgery and everything. So.
Just to build on that, OA usually presents following fractures that extend into the joint space is kind of like the primary thing people watch out for.
Yeah, but I mean, some of these do. So you have this fracture kind of extends here, but you can see how this is actually going, this image isn't the best for it, but this would extend up towards the end plate there. Whether it's, you know, causing enough of a disruption, I don't know, but these are more mellow fractures, of course. So.
I have a question right now.
Yeah.
Do you have any sense, like I assume you probably don't have the data from these people, but how readily prescribed opiates are in Switzerland for like post-fracture healing? Like this could explain, you know, half the variance here. You want to get rid of bone, you know, pump someone full of opiates.
So none of these people got opioids. I know that.
So that is, yeah.
Yeah, and I don't think Switzerland is as gung-ho. I guess it's being recorded. Switzerland is probably not as gung-ho about opioids as it is here for chronic pain or this short-term, like this is low level pain, right? These are pretty mellow, like in the scheme of things, mellow fractures. So no, and they didn't get, I think they were screened for osteoporosis, but they weren't prescribed bisphosphonates through the study or anything like that. So.
Okay, Matt?
Yeah, I was debating whether I should say this or not. I'm just still going back to the question that
came up about whether these void spaces, they're sort of like a cellular thing to do with the bone,
Yeah.
and then you've got this data about hand grip strength. You sort of put up two boxes that says like, you know, kind of chicken and egg or causal, I guess, if I understand it correctly, right?
Yeah, like which way is it? Yeah.
Yeah, and then when I look at your graph, and the reason I asked about body mass normalization is like, you know, so bigger people tend to have more grip strength, smaller people tend to have less.
Yeah.
And you started wondering, because you kind of see the females, and then there's some males.
Yeah.
Right, and it's all absolutes. I would imagine the males just on average probably have more absolute strength.
This is that relationship is the exact same. I just forgot to change the slide. It's the same if you do relative grip strength, right?
Same
it's the same, yeah. So if you look at just females, for instance, it's the same. It's same relationship.
Same pattern
Yeah.
shakes out. And so then, you know, what you start to wonder is, I think it kind of goes back to the question, is it literally to do with something as simple as you're able to like load up your
hand,
or just to keep the muscles strong, that it would be enough, or if that is totally irrelevant. And
yeah.
I guess, is there any, like, do you think it's worth, from your perspective, is that a question you're interested to pursue? Is it something like where, you know, you can look at after the cast comes off, strengthen, does it come back more quickly?
Yeah.
It would seem like a really easy study to administer. Like, you know,
yeah.
Any thoughts, like where you?
No, yeah, I definitely think it's very worth exploring. I would say, and it's something that is a low risk intervention, right?
Oh, yeah.
So following this up, and now that of course I'm starting my position here, have my own lab, that's absolutely something that I do want to explore, especially looking in individuals that are perhaps less complex, so younger age range where you're not confounded by like lifelong effects on bone.
Sure.
And just looking at understanding, does the intervention, if you have different groups doing different interventions, do you actually see a difference there? And a lot of lessons learned from these cohorts where there's sort of leakage on what's allowed for recruitment, what's included, keeping it constrained and focused, I think it'd be very worthwhile to look at, because it could be very easy to implement and could give a lot of insight into how maybe you could just tweak care a little bit to improve outcomes. Definitely agree.
All right.
And very interested. If someone's interested in that sort of stuff, let me know. Yeah.
I'm just building on the mechanical, like,
the mechanics.
Counterpoint to the mechanic. Don't be on the road. I'm a mechanical person. If you loaded that bone in axial compression, you would see the greatest strain. Not thinking you're gripping.
Yeah.
Your axial, you're going to see the greatest strain in the proximal area where you've got all the trabecular bone. It's not going to be distal where you're losing all of the bone. If you don't load it in axial compression, you load it in bending. You can see all the strain in the cortex bone. None of it's going to be loaded in the marrow. So mechanically, it doesn't make sense to me why a disused situation would lead to bone from that location.
To be lost, yeah.
If it's characteristic that it's sort of always there and that it seems to be really close to the marrow.
Yeah.
Medullary canal is what I mean
Medullary
when I say
canal,
marrow, right? Like, yeah. So, so I would, that's what my brain
Just thinking, yeah.
Yeah.
Yeah, and it warrants more investigation, especially with, so I don't think this is a sufficient FE model to perform to characterize the mechanical environment of the bone. You need more, extend further, and you need to actually do those sort of assessments, I guess, or analysis, some adaptive load history. So I do agree, there's more into it. And I don't know, so I think the one comment I would have is the mechanical environment here, if you're looking at it, maybe in bending, there's a lot more going on, but I don't know in this region.
It's not going to do anything there.
Yeah, and so here, this is the least mechanically necessary bone.
Yeah,
so
you
if you're
don't
gonna,
need it.
you don't need it. So when your body's responding to this like emergency over here, it's likely going to go and take resources from the region that's least needed. It's not like lack of mechanical stimuli, it's the lack of need mechanically. And I think that is, so there is not just mechanics that are driving this, but it is also an actual response. And I think that's a feedback loop.
In the body are smart enough to do that, but that would be like amazing.
Yeah, maybe. Who knows? I mean, it's close enough that it's like, but yeah. Anyways.
Andrew, and then
For general activity levels, like I know they're reporting of doing rehab is bad, but do you have like general activity levels like,
For these people?
For these people pre-injury and during injury?
No, we had like calcium and vitamin D intake, and then we have their post adherence to the rehabilitation. We didn't take detailed information about like any physical activity levels prior, unfortunately,
So it might be interesting, even just if you do something similar in the future, just
to
get,
capture
like,
that.
daily activity, like what were you doing? Like,
Yeah.
Work a manual labor job, or your arms broken.
Yeah.
Figuring out how to support things with the edge of your cast, and not using your hands. So you're
It's
just
true.
Being active with both arms.
Yeah, it's a good point. Yeah, I think, yeah, in reality, though, that day-to-day information is, or the daily use and lifestyle information would be really helpful for that sort of, or narrowing the focus, right, on a specific cohort.
Seems, you gave a very interesting
Yeah.
answer to that when you said grip strength, and I can take groups apart and it's related to females. And I agree with that, but it's not related to the males, the way I look at your graph.
Yeah.
So I just wanted
That's
to point,
fair, yeah.
to point that out. The females would give you the same relationship to the males. The males, I don't think would.
I know, yeah. So the males, there's not enough males, and so I can tell you that the males include the 18-year-old and the 85-year-old as well. So
Which is interesting. It's interesting because grip strength supposedly in the elderly is related to mortality risk very
Yeah.
strongly.
Yeah.
And last but not least, what I wanted to say, since this is presentation from the ETH Zurich and I'm born, so Ralph Müller, as you probably know, is organizing the ESB next year, European Society of Biomechanics in early July. 2 weeks later is the ISB in Stockholm. So if ever anybody wanted to go to Zurich and Stockholm,
it's a good chance.
that would be the place to do it.
Yeah, it's true. It's a very nice place to go.
Okay, we'll wrap it up there.
Yeah,
So let's
okay.
thank Danielle again.